Let's get started. Welcome everyone, and thank you so much for joining our webinar. Today we have Doctors Doyon and Tamryn Gray launching their Health Equity and Anti-Racism Special Interest Group with their webinar, Principles for Health Equity Research in Palliative Care. Just a couple housekeeping items. All attendees are muted and video cannot be turned on. We also ask that you please use the Q&A feature to type in your questions. And if any questions come up or more technical, we ask that you please use the chat feature. Please share your questions and comments at any time, and we'll answer those in the last 20 minutes of today's webinar. Also on our panel today, we have Drs. Ronit, our keynote speaker, and Dr. Christine Ritchie, co-chair of the PCRC. So I think we can get started, and I'll ask Dr. Ritchie to please formally introduce our speaker.
So greetings everyone, and we're so glad that you joined us today for this inaugural webinar for the launching of the Health Equity and Anti-Racism Special Interest Group of the PCRC. We're so delighted to have as the lead of the HERE Special Interest Group two very promising up-and-coming neuroscientists, Dr. Tamryn Gray and Dr. Kate Doyon. Dr. Gray is a health services researcher at Dana-Farber Cancer Institute and Brigham and Women's Hospital. She's an instructor in medicine at Harvard Medical School. She employs mixed methods, big data, and implementation science to investigate the complex medical, decisional, psychosocial, and socio-epidemiological factors influencing care delivery and health outcomes for persons with serious illness and their caregivers. Dr. Kate Doyon is a second-year T32 postdoctoral fellow in palliative care and aging at the University of Colorado. Dr. Doyon is passionate about improving care for patients with life-limiting illness and the nurse's ability to provide socially equitable care. Her long-term career goal is to have a research-informed curriculum in schools of nursing on communication with patients with serious illness and communications with ethnically diverse patients and families. We are really delighted to have both Dr. Gray and Dr. Doyon lead this webinar, and we're so also grateful to have Dr. Elk join us, and I'll turn it over to Dr. Gray.
Hi, everyone. We're so excited to be here today to kick off our new HERE SIG within PCRC. As Dr. Ritchie said, my name is Dr. Gray, and first I want to provide kind of an overview of the presentation today. We'll first talk about what the new HERE SIG is, and then my colleague, Dr. Doyon, will introduce Dr. Elk, and then we'll have our wonderful keynote speaker, Dr. Elk herself. We'll also open up for a Q&A as well as a wrap up at the very end to let you know about next steps for the SIG. So I want to actually have Dr. Ritchie just kind of speak briefly about PCRC. It is a wonderful collaborative that's sponsored by NINR. And we are so grateful to have the support of PCRC, NINR, as well as the leaders within PCRC. Dr. Ritchie, can you have a few words to share?
Certainly. So the Palliative Care Research Cooperative, which has now been a part of the palliative care research community for 10 years, has been a flagship program of the National Institute for Nursing Research, which has been its key and only sponsor throughout its history. The Palliative Care Research Cooperative Group has over 500 members and is a part of over 200 institutions across the country. It has supported a number of different important research initiatives and supports the investigator development of palliative care researchers throughout the country and actually throughout the world. And part of our work is to support people who have specific interests within palliative care, which is why we started the Special Interest Group program. We have special interest groups in a number of different initiatives in kidney disease, in heart failure, in new career investigators, in a number of other, in digital health, and a number of other special interest groups. And if you go on our website and you don't see a special interest group that's important to you, we'd love to have you think about starting one. We'd love to support you. And I'll turn it back over to Dr. Gray.
Thank you so much, Dr. Ritchie. So as she said, if you see that there's a gap, let's do something about it. Kate and I, we started this new SIG, Health Equity and Anti-Racism SIG, also known as HERE. And really the overall crust of this SIG is to create a sense of community as well as activation within the central domains of health equity and anti-racism in the context of palliative care research. So when we think about, what kind of domains do we want to have for our SIG? We've talked with our leadership team, and I'm just going to outline or just describe briefly some of the brief domains that we want our SIG to really focus on. So community outreach and conversation, being able to connect to the community, but understand how our research can influence and how we can learn from the community. Because PCRC is focused in palliative care research, we want our SIG to be an avenue to be able to promote research training and education within the space of health equity and anti-racism work. We also want to expand the pipeline. We know that there's investigators just kind of along the trajectory from early career to more experienced senior investigators. We want to make sure that our SIG has a component of supporting and expanding the pipeline, people who are interested in this work from an early stage, being able to have a peer mentorship to really influence how they want to influence in this area. And then assessment evaluation. It's critical that our SIG have very deliverable outcomes. So we want to continue to assess how are we doing, what do we need to focus on, what objectives are we really meeting when it comes to different performance measures and writing and collaborating and really moving the field forward. So we'll be doing ongoing evaluation. We had a new SIG survey that we are so happy that there's a ton of responses and we got a lot of great feedback. We'll talk about that in a few minutes. But we'll be doing some ongoing assessment and evaluation just to make sure that our work is really meeting the needs. And then we want to increase visibility for investigators doing this work, visibility for the work itself, and visibility in the impact of the work. So we really want to make sure that our SIG is active on different platforms, online platforms, as well as in person, where we can finally meet again at our investigator meetings to be able to really talk about what our SIG has been doing over the last year. And the thread that is kind of throughout the cross-cutting theme throughout these domains is, of course, research. Research is going to play a role throughout all of these domains. So our mission statement, the Health Equity and Anti-Racism Special Interest Group is an interdisciplinary community of researchers committed to developing solutions to reduce health disparities, increase health equity, and promote anti-racism by designing and implementing evidence-based interventions to benefit and serve marginalized and underrepresented populations with serious illnesses. So how are we going to do that? We seek to achieve this mission through the generation of new knowledge. We are a research SIG, community, training, and awareness about ways to address health disparities through palliative care research. So as I mentioned, you all were so wonderful in filling out our survey as we gauge interest into what it is you want to do with this SIG. What do you want to know about? How do you want to be involved? So I'm just going to provide some preliminary results just so you have an idea of the interest that's already forming. So top interest from the survey so far with regards to interest include people wanting to really have an interest, people have an interest in marginalized communities and communities of color, immigrant health, scholars of color with expertise in palliative care, state and national policy reform and advocacy. And in this SIG, we really want to make sure that we have Black and brown voices and faces a part of our different activities. We want to be able to hear from those unique experiences from others. And then in terms of activities, what do you all want to do? What are we going to do? So top activities really include writing and publishing manuscripts together. And these are by way of rank order. Generating and submitting grant writing proposals together. Engaging in training that promote confidence and competence in this area. Inviting national speakers who serve as experts. And then, of course, hosting webinars related to health equity and anti-racism were among the top. And then in terms of topics that you want us to think about in these activities, there were topics that I guess some of the popular topics include barriers and strategies to achieving health equity, focusing on social determinants of health, examining methodological strategies and conceptual frameworks, and looking at levels of systemic racism and its impact on health. So you all have provided a lot of great ideas as we think about our initial steps for the SIG. So next, I'm going to hand it over to my wonderful colleague, Kate, who is going to introduce Dr. Elk.
Okay, thank you. It is with pleasure that I introduce Dr. Ronit Elk, a professor in the Department of Medicine, Division of Geriatrics, Gerontology, and Palliative Care at the University of Alabama, Birmingham. And she is also the Associate Director of the Center for Palliative and Supportive Care and of the Southeast Institute for Innovation in Palliative Care. Her research focuses on partnering with underserved communities to develop culturally concordant palliative care interventions based on the community's cultural values and preferences at end of life, and in training clinicians in providing the culturally concordant care. Dr. Elk has published extensively, but is most proud of her work as a guest editor of a special issue in the Journal of Palliative Medicine, focusing on palliative and end-of-life care for African Americans. Her editorial is titled, "The First Step is Recognizing, Acknowledging, and Respecting the Inequity, Disrespect, and Disregard for African American patients, our African American patients have experienced." We are thrilled to have Dr. Elk as our speaker at our here inaugural kickoff. And so Dr. Gray and I will be monitoring the chat. So please feel free to type a question to the chat and we'll do our best to get to the questions. And I'm going to hand it over to Dr. Elk to begin our discussion.
Hi, everyone. My name is Ronit, and I'd like to start this off by saying two things. Number one, I give huge kudos to these two beginning investigators who not only created such an incredible SIG, but when I heard of their title with the anti-racism part in it, I mean, I could have done cartwheels. Had I been young enough, I probably could have, but I'm not, so I can't. I think that it's so important that they are actually naming it for what it is. And I'd also like to thank both the leadership of PCRC and, of course, the NINR for really supporting this kind of work, which is obviously so important. The NIH has recently come out with a statement about anti-racism that NINR strongly supports, which is very incredible. The second thing I want to say is this is a mistake. I am not giving a talk. I thought I was, but no. The group would like us to, I haven't forgotten to share my screen. I will. Do you see it or not?
Yes, we see it.
Perfect. So the group would like us to talk about certain things. So I'm just going to talk about a few things. And the point is for us to have a conversation, which Dr. Gray and Kate Doyon will also help us facilitate. Now, the starting is by looking at what the definition of health outcomes are. And I've highlighted a few things that they've put in there, the differences in health outcomes. But you might notice that, first of all, we have become so used to talking about health disparities. I myself, when I was at the American Cancer Society and a director there, developed a program on cancer health disparities. There are programs that the NIH funds in health disparities. Have we become immune to that word? Do we think that this is something that's always going to be there? No, it is not inevitable. It is not necessary. And in fact, it's immoral. So it is a priority upon us to, in fact, make sure that we work to achieve health equity, not reduce health disparities. People used to talk about reducing health disparities. No, we want health equity, and we want the word health disparities to be gone because it won't exist. one of the interesting things that I saw on this definition, and many other definitions, is they look at social factors and they look at psychological factors and so on. But the factor of systemic racism has, until last year and the tragic murder, which was one murder too many, that has spurred the whole world to look at systemic racism flat on. So it's missing from this definition, but I'm happy to see that the world has changed. And since 2020 and 2021, this has been coming to the forefront. There is a slide that Dr. Gray had specifically asked me to talk about. If anybody on this call believes that race is a biological construct, you're on the wrong call. I'm sorry, I don't know how else to say it. I know it's not very polite the way I'm saying it, but the whole issue of race was imposed on us by historically, and has lived on in generations as, oh, this one's of this race, this one's of that race. You could ask Dr. Johnson, who's on this call, who is the leader in achieving health, working towards achievement of health equity in palliative care, and of the discussions we have had about this issue of race. And so every time when I hear people say, oh, this is a race, you know, the hairs on the back of my neck stand up, and I hope on yours too. One of the things that I really wanted to add is the National Institute of Healthcare Management has come up with what I think is a very wonderful, it's two-part slide. It's so long I had to divide it in two. And they talk about, they demonstrate in this beautiful visual, this horrific situation about how systemic racism, which they define as policies and practices of big organizations, how they advantage some populations and they disadvantage others. So therefore it creates different health outcomes. So that very polite social, that word about social, due to social reasons, it really is not. Yes, those factors come into it, but systemic racism is a policy and it's a practice that goes onto societies, and they give many examples. One is about COVID, but also they talk about long-standing inequities that impact health. So food insecurity, how many of us have ever faced hunger? I know some people may have had a situation where they've had maybe a day or two of being hungry, but when you can't feed your family, or when you literally don't know where the next meal is coming from and it's ongoing, the food, it's called food insecurity, and Black Americans are double more likely to face hunger. And you know, if you're hungry just on a regular day, how your mind sort of not even focusing, imagine happening that all the time. Black individuals make up 40% of the homeless population. Wealth and the financial situation, the housing insecurity, we're talking about homeless. There's also this whole thing about giving mortgages to certain people, restricting certain areas from African-American families. No wonder the wealth is, we have historically, when the wealth of the African-American community has risen, there are many communities where this has happened. Somehow the white group around has come up and managed to destroy by killing the people and destroying those communities. Yes, you may say this is history, it's not happening now. It is happening now, ladies and gentlemen, and history lives on the genes of all of us who have suffered such horrific situations. Very much lower education and mass incarceration, which we shouldn't even talk about because it gets my blood pressure so up, because so many of the people who are incarcerated in the United States at the moment are actually there. They certainly do not need to be incarcerated. They're there because maybe the license expired and they don't have money to pay for parole. And then they give you this graph is so beautiful about how you have your body, if you have stresses, particularly things like racism, or in my family, for example, it was the Holocaust in Europe. You know, what happens when the situation is such a chronic stress and years and generations, and the load that it can have on the human body and what it does as a health outcome. This is the most fascinating slide. I've written a superb, well, I shouldn't say that. I've written an important paper on the effect of systemic racism in certain situations, and I'd be glad to share it. So the group wanted us to talk about some questions for us to start us thinking. Should we in palliative care have a reorientation to explicitly integrate the premises of health equity? If you ask me and Dr. Johnson and many others too, the answer is of course. Dr. Johnson, I mean, she's going to not be happy with me for saying this, but Dr. Johnson works like a complete, I don't know what, with very little rest. And her whole goal is to try and to make health equity a priority in palliative care. And to me, the sad part is that she's been doing this for many, many, many years. And why has it taken us so long to get ourselves moving? Many of us, maybe 10 or so of us, have been doing this for many years. No one as long as Dr. Johnson. And now what is wonderful is seeing all the young investigators coming in. Very, very, very gives us so much more hope. The second question they wanted to discuss is, what are the domains of the medically underserved groups? Who do you want to focus on? Do we need to have an argument as to whether, no, we should only focus on African Americans? No, we should only focus on immigrants? Do what is passionate for you. Do what you care about. Any group that's medically underserved or vulnerable requires somebody to champion it, or somebody's to champion it. So go for that. Let's not argue about it. Let's just all focus on every group that we want to. And then we're going to talk more about the strategies to reduce these barriers. I told Dr. Gray and Doyon that after this slide, I'm going to hand it over to them to start facilitating some of the questions. They have a whole list of questions. And I think that Dr. Gray gave us a very good overview of what this group wants to be able to do, which is to achieve health equity and to get a deeper understanding of the barriers. I would add certainly that to find ways by listening to the community, hearing the community, and most importantly, partnering with the community in order to hear their voices in what they want in palliative care and in the treatment of people with serious illness and end-of-life care. And with that, I'm going to end my part of it and hand it over to the three of us, I guess, to facilitate the conversations. Is that right?
Yes, thank you very much, Dr. Elk. If we can have the first poll, we have a poll just to see who is in on the call today. And I hope everyone can see the poll. If you can't see the poll, oh, good. Okay. It's populating now. We'll give it a couple minutes or a couple seconds here so we can see what specialties we have in our midst today. Okay. I think that's good. Can you share the poll? Share results? Okay, a lot of other. I don't know if you can see this, Dr. Elk, about half of our participants are currently conducting research in health and equity.
Oh,
I can't see that one.
we just see the first question about what's your profession.
You can scroll down. Are you able to go on your screen and scroll down? Yeah, there's 2 questions in this poll. I'm going to go to pull up the chat questions. Let's see. As a palliative care social worker, these efforts seem inherently necessary for ethical practice. Thank you for explicitly demonstrating the urgency of this need. And then, oh, and here's, I answered other. I am a public health policy person. Thank you, because there's a huge portion of other, and I was wondering what other.
And actually, one question that I want to kick off, if that's okay, Kate, is the question about how do we integrate research focused in palliative care and public health, as we have individuals who are public health experts and policy experts. Dr. Elk, do you have any advice on how to integrate health equity research, palliative care, and really bringing in our colleagues in public health and policy?
So let me answer it in 2 different parts, and then let's hear from the audience also. So the public health, the method that we use, the one that's called community-based participatory research, which is a method where you partner with the community, has actually a method that's been a social justice method. So for the social worker on the call, I know you are so well trained in social justice and the focus on social justice. So this is a method that public health professionals use. It is also a method that preventive medicine people use to try and prevent illnesses. It is not a method that's being used in medicine, and so as a result, neither in palliative care. That is a method that is, it seems very simple. You just partner with the community and there you go. It is actually much more complicated. I will give a little plug to say 2. One is that I am going to be doing a training in community-based participatory research sometime in August. And probably only have 30 to 35 this year. But if you're interested, send me an email and we'll put you on the list to see if you're interested in it. It's going to be a 2.5-day immersion, but you have to immerse to be able to get yourself immersed in order to do this. So that's a public health method, and we certainly can collaborate on that. The other aspect is ethics. I'm collaborating with people who do ethics. I wish I had found these people experts myself before, because instead of my ranting and raving and not having the language, the ethicists have the most fantastic breadth of knowledge about ethics. And in fact, we have a young person, a beginning investigator, who has submitted a supplement to the grant that Dr. Bakaitis and I have, focusing on a special issue on trust in the African-American community. Key issue. So that's another group we can partner with. And as for the policy and public health people, I've been known to say, I'll kiss your feet, because you can make such huge systemic change by changing policy. Changing practice is not as quick as we think. Oh, you got 7 more chats.
That's fantastic. Yes, so the questions are rolling in. So I'm actually going to, and Kate, will you tackle the next question after me? So there's some comments. Individuals say, Shawi says, I'm a pharmacy educator and researcher. Someone else, Mary Ellen, comments, and she says, my other role is faculty at School of Nursing, conducting research and including health equity in graduate classes. And then Levi asks a question. Well, first they say I'm a chaplain, and then the question is, how can I get involved?
Oh. Well, to the chaplain, let me answer that our work partners with African-American pastors and chaplains very, 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 very much. it would depend on where you are. I can tell you that we do have another training. The point of this is not to do any plugs, but we just happen to be have this, in which it's called Communities Speak to Healthcare Workers, African American Communities Speak to Healthcare Workers. And it's a partnership where we partnered with the African American community in the rural South. I'm hoping that somebody wants to replicate this up north. Anybody? And so we can do that training and people can participate in that. But to the chaplain, I wanted to say we have a chaplain who talks to the group and explains the importance of, or the role of religion in the African American community. And you can see people literally getting an understanding, very, very much an understanding. Also, we work with community advisory board members, and if you are going to partner with an African American community, you must partner with partners, particularly in the South, as they are the leaders of the community. So we partner with a lot of pastors, and when we have focus groups, we always have two focus groups, one with sort of caregivers or people with serious illness, and another with African American pastors, always. Yes, this is just beginning this kind of work, but as we're mentoring more and more people, it's going to keep spreading. It'll be like yeah.
Kate, do you want to tackle the next question? You're muted right now.
There we go. I have another good question I might as well be asking myself about too. As an early career researcher feeling inadequately prepared to discuss structural racism, health disparities in my manuscript, I wonder if there are any tips for approaching this sensitively.
Oh, this is so good. This is such a good question. And you know why? Because if you'd asked it 2.5 years ago, I would have said, it's difficult because people don't want to listen. You have to be more polite in America, in this country. Maybe in Britain, you could do it differently. Now, oh my goodness, it's not only have people become I call it woke, but people have become awakened to this. They're realizing it. And in fact, I've had people say, oh my gosh, what's going to happen? My grant, will the reviewers understand it? Will they be open to it? And yes, there has been an increased recognition. And so the Journal of Palliative and Journal of Palliative Pain and Symptom Management, the Journal of Pain and Symptom Management, we did a special call on papers addressing systemic racism in palliative care. And people are writing the papers. I'm fortunate that I'm doing one with Dr. Gazaway, who I believe might also be on this call. And we're going to be talking about, never mind, I better not say anything. That particular issue is now becoming very much more, just say it the way it is. Look at the literature of where it says that talks about structural racism and the effect on it, and just write it. And if the reviewers don't understand it, they need to get better reviewers. Definitely do it.
There is definitely always more work to do. So Levi actually have a comment that I want to change into a question. And before I ask the question, I wanted to really say something that was on my mind during this webinar, which is for individuals who want to do this type of work, but have little diversity, racial and ethnic diversity in their geographic region, how do you advise that they get involved in this work? So that's kind of one question. And to Levi's point, they say, I'm an African-American clinical chaplain. There are so few colleagues in the North. So really, I think it's a broad question of what do we do when the numbers aren't there for collaborations or for research?
The wonderful thing about Zoom, there have been so many tragedies with COVID, and of course, Zoom was around before COVID. However, the change is you have no idea how many people I collaborate with that are in so many different states and in so many different countries. The country part is not always easy because, oh, you can't hear, there's wind, there's storm in Ghana. But in America, it's very, very, very possible. And I mentor people all over the country. What's the difference? You see each other on Zoom. So whatever you can do, anybody, please collaborate. And if you're going to study or work with people of color and you don't have people of color, there are millions of people who would love to work with you. Please approach them, invite them, and on a Zoom call, all of us are here. And I'm really sorry, it must be really hard for Reverend Gauss to be without colleagues. That's a bummer, but I'm sure that, I mean, I have somebody who's going to be doing a study with me and she's in Boston. So maybe we can find a way of collaborating.
And that could definitely be a focus for our SIG as we're thinking about bringing about community and making sure that the community becomes a little bit more well known and people can know who to connect with others with doing interesting work. Kate, do you want to tackle the next question?
Yes, and I also wanted to add that having meetings like this and attending the SIG meeting where you learn how to send out essentially a cold email to someone so that you can connect. I mean, that's how I connected with Dr. Elk.
Mm-hmm.
So we have another good question from Jory. Are there resources or best practices on how to structure demographic elements within surveys that are more culturally sensitive and open-ended?
Oh, this is a whole course. The first thing I would do is definitely look at, I'm not sure, is this for research? Is this for, oh, what are the social media handles? People want the social media handles. I'm not exactly sure. Can I think that
I wonder if we can assume for research. Yep.
Can we have them talk? Can Jory talk? Naomi. Oh, for research. For research. Yes, there are lots of best practices. One of the main ways of doing that, I don't do survey research. I do, more qualitative, but there are articles on how to, oh, there's Jory.
Yeah, I was just, in particular around, categorizing people and putting terms like other within demographic surveys, even to get a sense of the patient population for qualitative research. Just curious if there's new and kind of up and coming ways of doing this in a more sort of culturally sensitive manner.
Right. Frankly, other feels a little bit, if I was an other, I always click myself because when we go to, in America, they ask you if you're white or African-American or this or this or this. And I always click other because I'm not white and I don't fit into the others. But I can tell you that other doesn't feel so good. It's like, oh, well, you're just an other. So I think that in any way that you could be respectful, that doesn't really answer your specific question, but it's sort of like if you're working with the LGBT community, knowing how to address people, you really, if you're not familiar with it, go to the literature to see how people want to be talked about. Or there was a whole thing about how African Americans, be respectful of how African Americans want to be called, that sort of thing. Does that answer, Jory? Not really.
Yeah, it does. And I think I'm beginning to learn about sort of strategies like leaving, just places for people to type in their own response and not giving categories, even things like that. Was curious to learn what people are doing.
And it definitely sounds like a good topic for an upcoming SIG activity. I know the methodological considerations was an interest for many individuals. So that's a great, Jory, thank you so much for being a part and elaborating on your question. So I guess one other question is, as we think about, specific underrepresented populations, Dr. Elk, you mentioned just go out there and see who needs, who has unmet palliative care needs. How does one go about kind of activating from recognizing populations in need to really initiating studies to benefit them?
That's really good. I mean, if you have a passion about, for example, one of the groups that I think is really difficult is people who are homeless, because you go, oh, how am I going to find them, etc. Well, there are other people who have actually started work with homeless communities. And I mean, they deserve more kudos than anybody you can imagine to do that. And therefore, you have to read what they do and ask how they do it. And then, depending on the kind of method, that's why you definitely need a methods thing. Because if you're going to do partnering with the communities, that's one whole way. And that's what the one that I'm going to teach about how to partnering. If you want to do it, definitely start by reading the literature. Anything that's been written about, somebody may have already done it. Or for example, let me give you an example. This whole issue of respecting culture we did it with African-American and white rural Southern community members. Well, there were two physicians, one in Ghana and one in Puerto Rico, who totally got, oh, and now there's a physician here who is Hindu, who recognized that the palliative care that we have here method is not culturally appropriate for all. So they decided that they would do it. And so I'm mentoring each of them in how to do that. If you're interested in a particular immigrant group or any other kind of group, then you look in the literature, look to see who's written a lot about it, who's done a lot about it, and then you can go and ask them if they would help you or mentor you, or do they know somebody else who you can work with, that sort of thing.
I think that's such a great point, because we know that we know that disparities exist. We know that there's a lot of injustices. We know that there's a lot of gaps in terms of who's getting palliative care and who's not, who's benefiting from palliative care and who's not. And we know that there's a desire, particularly within individuals who are here on this call today. And one of the things that you're kind of prompting me to think about is activation. And that's one of the things we talked about in our SIG, in terms of, who are we? We're about community and activation. And really, as you talk, I think about how we need to move the needle to really, when we think about interventions, to really figure out how we can make a difference and develop solutions versus staying on kind of the track and descriptive.
Right, and that's what always happens in the field. For example, in the Kent, there's always like, okay, let's describe what's going on. You need that. That's a first step. You have to know what's going on so that you can, determine the extent of the problem, who's having the problem, what kind of a problem, etc. And then you design interventions. That's why I love to design it with the community. Well, guess what? From designing evidence-based interventions to implementation can take 14, 15 years. Well, when I heard that at a talk on implementation science, I was, oh, I am too old to wait until these people get it. I have to get involved in that. And so that comes into training, which I see in one of the questions, somebody talked about training. And so we have a training that I told you about, it's called Community Speak to Healthcare Workers. It's only a 3-hour training if anybody's interested. It's just the beginning. It's just a beginning. What I'm hoping that in 10 years that there will be other people who partner with other communities, and those communities also create videos. Videos are not enough. I was wrong. I thought videos would be the answer. They're not enough. They have to be with training. In palliative care, there are many experts who are in communication training. So adding communication training to the voices of the community, that is a perfect way. And then you can measure to see, how do people change practice, and do the community members feel, oh, there's a change in my physician, something's changed. They're respecting my culture. They're respecting my values. They invited the pastor to come before they gave me bad news, or they understand the concept of hope. I mean, we've written about it. Writing about it is great first step. Does it make any change? I don't think so. It's very sad to say, but we've had a pastor, Pastor Corey, that's his first name, but that's what he goes by, who came to the AHPM, I don't know how many years ago. He talked about the concept of hope. There must have been 400 people in the room. He wrote an article in the journal that Kimberly and Dr. Johnson and Dr. Quest and I put together. He wrote an article in it. How many people have read it? I don't know. Has it changed practice? I don't know. Why not? Because people have to feel it, people have to experience it, people have to do it. And now that you have started this group, I see things are going to be moving like this.
And if anyone wants to say something, please feel free to share. Kate, I'm going to let you tackle the three, especially starting with Dr. Johnson's comment. The three.
Yes,
okay.
And it popped up on my screen and then it disappeared. Someone raised their hand, and I tried to give them permission to speak, but I haven't seen anyone pop up to speak. So maybe it was an accident. We do have some questions in the Q&A. So from Anonymous, how can we best utilize vulnerability indexes, for example, social deprivation index, to examine the impact of multifactorial social determinants on disparities in palliative care?
Can we have somebody ask that question? Oh, you're going to answer it? Somebody's going to answer it. I don't understand the exact question.
Okay. And now the question disappeared.
Will you go to Dr. Johnson's comment before you jump to the next question?
Oh, yes, Dr. Johnson, this is
because I responded, look under the answered.
Oh, this is really an awesome initiative. Looking forward to the work of the SIG. As are we. This is very excited to be a part of this group and to facilitate the work going forward. And our upcoming guest speakers.
And here's the question that was there that disappeared. It was under the answered. How do we best utilize vulnerability indexes to examine the impact? That's a whole research question. That's a whole research question that we need a whole group of us to sit around and talk about. What population are you looking at? What does the literature say? Which group are we at? You can't answer it. It's very, very specific. Too specific for this, to me. And May, can I answer that question?
Yes, please.
Mentorship. Mentor. Find somebody who does the kind of work that you're interested in, and ask them if they can mentor you. That's the best way. That's the best way to start. But also read a lot about what's being done. And one of the big challenges for people like myself is if somebody comes with an idea, but they haven't read anything about what's being done, and it's sort of like, oh, you don't have context. You need to have context about what's being done. And I would suggest that we have Dr. Johnson, again, she's going to be mad with me, but she's so nice, she doesn't really get mad. But for her to come and address this group, because for so many years, she's kind of been doing this on her own. Not that people didn't support her, but for so many years. So she's our heroine. And Dr. Quest has made huge policy changes at the AHPM level. And I should tell you that the meeting at the AHPM, we had a post-plenary meeting with Dr. Quest and myself and Dr. Vijay Periakoil, and they told us that the AHPM is committed to doing much more on this, including perhaps even a whole conference on racism and health disparities. Woo! And more, and trainings.
a lot of excitement, a lot of momentum in this area. And I think we're going to close with one final question from Brett. It disappeared, but the question was, how can PCRC members join the SIG and get involved? Kate, do you want to tackle that one?
Yeah, it disappeared because I answered it. So, and so I can answer it out loud too. It's we're going to go over how to join the SIG. Well, Naomi's going to go over it at the very end. And to join the PCRC SIG, there's steps you have to go through to essentially join it, create a Google account and then join that way. But Naomi's going to go over that at the end. And please feel free to share. So I know there's some people, some of our colleagues who wanted to be here today, who couldn't. The more the merrier. We have some events coming up and we'd like to share them with people who are interested so we can move this forward. And here's Tamryn, I'll let you talk about this slide because this is the upcoming events.
All righty, that sounds good. So first, I want to thank Dr. Elk for being here today. She's so inspiring and just really helping us.
Sorry, I'm just going to put my Twitter handle, but I couldn't remember it.
Yes, please put your Twitter handle down there. And if anyone would like to put their Twitter handle in the chat, please feel free. We want to thank Dr. Elk for her expertise, for her time, for her support as we generate this new SIG. We are so appreciative of PCRC leadership, as well as NINR, as well as the PCRC members for showing interest in this work in health equity and anti-racism. We are excited about the activities that are to come. Our first goal is to really create a community within PCRC. So how do you become a member? You can become a member today. I'll have Naomi during the wrap up talk more about that, but you can absolutely join. And there will be an annual investigator meeting this week, Wednesday and Thursday. And we will be, first we want you to participate if you're a member of PCRC. And if you're not a member, see if you can become a member. The next thing is Kate and I will be talking at the PCRC annual investigator meeting about our SIG, and we encourage you to attend. It's going to be held this Wednesday, March 17th at 4:30 Eastern Standard Time. And we will provide kind of an overview of the SIG in more detail and get to know all of you. And then attend our upcoming SIG meetings. We are looking at the results for the survey, and then we'll finalize a date. You'll hear more about that on Twitter and email, so you can get involved. We want to hear from you. We want to bring in your expertise and your leadership to make this SIG successful. And before I forget, I also want you to save the date for a health disparities in palliative care webinar that's happening in a few weeks, March 31st, 4 p.m. Eastern Standard Time. You can contact Lee Ellington or Megan Hebden at University of Utah to find out more. There's a flyer. We're going to have some great speakers, as you can see on this slide, including Dr. Johnson, who's on this call today. And so please mark your calendars and contact them for more information. And I'm going to pass it over to Naomi.
Thank you so much, Dr. Gray and Dr. Doyon and Dr. Elk, as well as to everyone who's joined today. If our attendees do go to our website, we have one more webinar posted for the near future, where Drs. Tammy Summers and Laura Hansen will present on Need Better Peer Review Skills for Palliative Care Manuscripts, Mentoring and Being Mentored. We hope that you join us for that webinar as well. We'll also be sending you all a post-webinar evaluation where I'll also attach instructions on how to become a member of the new HERE SIG. I just want to remind you all that you do need to be a PCRC member to apply for the SIG. So you'll see in my email both a link to become a member and then a link to how to join the SIG. But please also fill out that evaluation. Lastly, we have a couple of deadlines this week. One to apply for our Dementia Care Clinical Trials Intensive, which will take place this May 25th through 27th. The deadline to apply for that is this Wednesday, the 17th. And we also have the 2021 mentorship selective coming up, and that deadline to apply is February the 19th. And we hope to see many of you this week at the annual investigator meeting. So thank you again to our panel and to all of our attendees for attending. Take care, everybody.
See you soon. Bye, everyone.